Most blood pressure diet advice gets flattened into one command: eat less salt. That is partly right, but too small. The useful frame is pressure load: sodium, potassium, rich foods, body weight, alcohol pattern, overall diet quality, and whether medicines are already changing kidney handling of salt and water. If you only count salt crystals at the table, you miss the packaged food system and the physiology behind the cuff.
So if someone watches a video promising lower blood pressure in 2 weeks, what should they believe? Is the food pattern actually strong? Or are we mostly seeing people lose a little weight, cook more, and eat fewer packaged meals? And how do we avoid turning a real lifestyle effect into a countdown clock miracle?
Blood pressure is not a salt meter. It is a circulation system. Sodium tends to hold water in the vascular space. The kidneys, hormones, blood vessel tone, and sympathetic nervous system respond. Potassium-rich foods can push the system the other way for many people, supporting sodium excretion and vessel relaxation. That is why the same meal can matter more in someone with elevated pressure than in someone whose pressure regulation is already stable. That is why the first practical skill is boring and powerful. Read the nutrition facts label. Sodium is often coming from bread, sauces, soups, deli meats, frozen meals, and restaurant-style foods, not from the visible pinch at dinner. Comparing two similar products can cut sodium without changing the meal. It is a quiet substitution strategy. Same tacos, lower sodium beans and salsa, same breakfast, different bread.
I like that because it is actionable. But people also hear, eat bananas and beets. Is the better move really a potassium-rich pattern? Beans, potatoes, greens, fruit, dairy or yogurt, nuts, and less ultra-salty packaging. In other words, should viewers think in meals rather than trophy foods?
Exactly. The newer studies in this packet are not proving a magic food. They support the pattern idea. A Mediterranean-style healthy dietary pattern improves several cardiovascular risk factors in adults with metabolic syndrome features. In a small Australian feeding study, whole diet patterns created measurable microbiome and metabolite signatures tied to blood pressure and lipids. Those signatures are interesting because they may explain why two people eating healthier do not respond identically.
Where do we draw the safety line? If food potassium is good for many people, who should not start potassium salts, electrolyte powders, or heart-healthy supplements without checking with a clinician? I am especially thinking about kidney disease and people on blood pressure medicines that already affect potassium.
The person most likely to see a noticeable change is someone with elevated pressure, high sodium exposure, low intake of minimally processed plant foods, excess weight, or heavy alcohol intake. If baseline pressure is normal and the diet is already excellent, the same change may barely move the cuff. This is not unfair. It is how exposure works. The biggest drop usually comes from removing the biggest driver. And we should be humble about numbers. One exploratory cross-sectional study found higher nut intake linked with about a 1.13 millimeter mercury lower systolic pressure, mediated partly by lipid metabolites. Interesting? Yes. A prescription for nuts as a blood pressure drug? No. It is hypothesis generating. The useful takeaway is not walnuts cure hypertension. It is that food patterns may leave measurable metabolic fingerprints that relate to pressure.
What about apps, texts, and reminders? If the physiology is slow, do just-in-time prompts help by catching the real moments? The salty lunch order, the evening drink, the skipped grocery run? Or are they mostly useful because they make the invisible pattern visible before the next clinic visit?
Yes, but judge them by behavior first. Are you checking labels, cooking more, hitting produce and legumes, reducing alcohol, and logging pressure correctly? For the cuff, look at repeated home readings over weeks, not one dramatic afternoon number after coffee, stress, exercise, or a poor night of sleep. Blood pressure is noisy, so the trend is more honest than the single reading you emotionally remember. Shortcuts deserve extra skepticism. A 5-day modified fasting program in healthy adults produced transient cardiometabolic changes and small blood pressure reductions after refeeding, but those effects did not establish a durable hypertension treatment. Time-restricted feeding in older sedentary adults improves some cardiovascular measures, with mixed adherence when combined with exercise. These approaches may reduce calories or weight for some people, but they are not the same as a sustainable pressure diet. Medication is the other reason not to freelance. If a diet lowers pressure while a diuretic, ACE inhibitor, ARB, or other antihypertensive is on board, the needed dose may change, but that adjustment should be clinician-guided, especially with dizziness, fainting, kidney disease, pregnancy hypertension, or abnormal labs. The goal is not to avoid medicines at all costs. It is to make food and medicines work in the same direction safely.
If we turn this into groceries, is the simple version: compare labels, pick lower sodium staples, build meals around plants and lean proteins, use nuts or yogurt as unsalty snacks, and treat alcohol as a pressure variable rather than a harmless side note. That feels more doable than memorizing a forbidden food list. When should expectations change? If someone does the plan for a month and pressure is still high, or they get chest pain, shortness of breath, neurologic symptoms, severe headache, swelling, pregnancy-related readings, or fainting, that is not a nutrition optimization problem anymore, right? Diet can be part of care, but it should not become a reason to wait through danger. So where does personalization fit? If microbiome and metabolite studies can see different biological signatures after diet changes, should viewers use that as motivation to track their own response, rather than buying a personalized nutrition promise before the science is replicated?
Right. The compressed answer is, use diet to reduce pressure load, not to chase a miracle food. Start where exposure is highest, usually sodium-heavy packaged or restaurant foods. Add potassium-rich whole foods if safe. Watch weight and alcohol. Measure repeated blood pressure. Coordinate medicines. Emerging biomarkers may eventually sharpen this, but today the strongest move is still a realistic pattern you can repeat. That is more powerful than a low-salt list.